Nós vamos ter a palestra agora do professor Alex Vitkin. Ele é do Canadá, da Universidade de Toronto. Ele está muito envolvido com aspectos da interação da luz com a matéria, com aspectos de diagnóstico, com aspectos de tentar entender o que acontece quando a luz, quando a gente joga a luz sobre os tecidos. Trabalha também com terapia fotodinâmica. Ele não é um especialista em laser de baixa, mas a gente achou que era uma boa oportunidade para vocês terem uma palestra, vocês terem uma ideia para onde vai indo a tecnologia da chamada biofotônica. Como ele é de um dos maiores centros do mundo, juntamente com alguns pesquisadores como o Brian Wilson, que é a grande estrela na área de terapia fotodinâmica e fotodiagnóstico. Então nós achamos que seria interessante, ele já está aqui no Brasil, e ele vai então nos oferecer aqui uma palestra. Tem duas palestras convidadas internacionais no encontro, a dele e a do tio Cuca. Então nós vamos ter a dele agora. Eu pedi para ele se organizar de tal maneira que a gente possa pelo menos fazer uma pergunta ou outra que a gente não tem conseguido até o momento. Embora não é muito comprometedor, porque nós vamos ter uma mesa redonda no final com os palestrantes, né? Então a gente vai poder usar as apresentações como ponto de partida. Mas no caso dele, é isso ou nada, então é melhor ter um tempinho para a gente poder discutir as questões. Espero que todo mundo goste e em seguida nós vamos continuar com a programação que está aí no programa, tá certo? Então, muito obrigado. Alex, now is with you.
Okay. So, thank you very much. I have no idea what he said, but I'm assuming it was kind of nice because I don't speak Portuguese. So, unfortunately, I'm going to have to speak in English. I'll try to speak slow, and hopefully most of you can understand it. A second thing I want to say is I don't actually do low-level laser therapy. We do some of it in our lab, but not in my research program. So what I'll talk about is another technique that we do use for a variety of diagnostic and treatment monitoring applications. And I think that technique may actually have a role to play in the dosimetry and quantification of low-level laser therapy. So with those two provisos, I'm going to move on to my talk. Again, if there's something you don't understand, either scientifically or the way I'm pronouncing things, please interrupt, or I'll try to leave sufficient time for questions so you can question me later. So I'm going to talk about blood flow imaging, so microvascular flow, so kind of perfusion level flow in tissue, with a technique called Doppler OCT. OCT stands for Optical Coherence Tomography. And as time goes on, I'll explain what that means. And I come from Canada, and I just happen to be here visiting Professor Vanderlei and his students and his laboratory and giving a whole bunch of lectures. So it was very convenient for me to come listen to this symposium and actually present something here as well. So let me move on. Where is Toronto, or where is Canada? So you probably know Brazil is obviously over here. So the other large country in the Americas is Canada. And the star is indicating where Toronto is. And the other features are the 5 lakes, the Great Lakes, close to where Toronto is situated. So it's about 8,000 kilometers northeast of here. It takes me about 11 hours to fly back and forth. That's a long, long flight. Toronto is not very big by São Paulo standards. I guess it's only about 5 million people. Quite a few English, French, and just about every other nationality in the world that lives in Toronto. So it's really a model for a mini United Nations. We have 75 different nationalities that are represented, and actually some more as well. It's the capital of Ontario, which is Canada's largest province. And if any of these statistics don't make any sense, the one thing that people will always understand that it's very close to Niagara Falls. So it's about 2 hours from Niagara Falls. And those falls are actually a little river that connects 2 of the Great Lakes, Lake Erie and Lake Ontario, and huge falls over there. So that's where I come from. More specifically, this is just a location of the hospitals where I work. I'm actually not based in the university. I'm a medical physicist, so I'm based in the research and clinical hospital called Princess Margaret Hospital. It's a very big oncology, radiation oncology and medical oncology center. It's part of a 3-hospital consortium called University Health Network, and that comprises Princess Margaret, this huge hospital called Toronto General Hospital, and close by is a Toronto Western Hospital. And then there's a lot of other hospitals, so if you get sick, this is a place to be, because there's many other hospitals that can help you. Mount Sinai Hospital, Rehab, Hospital for Sick Kids or Sick Children's Hospital, Women's College Hospital, and a whole bunch of others that are not represented on this map. And just very close to us is a big university called University of Toronto, also about 60 or 70,000 students and many faculties and so forth. We have a couple of new additions called something called Mars. It's not a planet, but it's medical and related sciences. So it's a new venture that the government of Ontario has just started, and that puts together biotechnology, high technologies, venture capitalists, and intellectual property business development people. So it's a method of commercializing scientific research. We also have a Toronto Center for Phenogenomics, which is a very fancy word. It's basically a mouse imaging center. So a lot of people are using mice as disease models for a variety of things, both for genetic diseases, for treatment monitoring, etc. So there's a lot of specialized installations in this place that look at mice as a screen, as a preclinical testing model for a lot of the cancer and non-cancer related work that goes on in Toronto. Can everyone understand and hear me okay? Okay. So just some pictures as to what some of these buildings look like. They look like buildings and laboratories and hospitals, etc. So specifically, zooming in a bit and looking into biophotonics, we have a fairly large group, about 50 people or so, with our strengths are basically physics and biophotonics, biomedical optics, optical engineering, but we also have a strong presence in biology and clinical science. Some of you may have heard of a person, a fairly big person in the field. He's the head of our group, called Brian Wilson. He's a big name in biophotonics of various, both therapeutic and diagnostic. We have a couple of other professors, and this actually speaks to the international nature of Canadian culture, because none of us are really born in Canada. So he's born in Scotland. He is from Germany. I was actually born in Russia, in Soviet Union, and he's from China. So we're all Canadian professors, but we're all kind of converging in Canada right now. So again, a fairly interdisciplinary group. We do everything from kind of basic science and basic engineering, physics, biophysics, all the way to preclinical testing, all the way to clinical implementation, and then back to iterate and make it better again. We're also putting together a website that's actually worldwide called biophotonicsworld.org, of which ourselves and University of California at Davis are the 2 central sites. So if you're ever interested in what things are happening, not only in our lab, but in the biophotonics in the world, you should check out the site. It's an initiative from Canadian Institute of Photonics Innovation and National Science Foundation in the States. So the kind of stuff we do there is we obviously have a lot of grants to support 50 people in doing the research. The emphasis in our lab and in our group in general is not just fundamental physics or biophysics or clinical science or biology, but actually clinical translation. So we do a lot of bench-to-bedside translation. We collaborate a lot with industry and sometimes start off our own companies based on the research we produce and the clinical collaborations we produce. And although we're based in Princess Margaret Hospital, which is a cancer hospital, a lot of our research is actually encompassing things like diabetes, regenerative medicine, infection control. There's a very large group in Toronto based on stem cells, and regenerative medicine based on cancer stem cells and non-cancer stem cells. So there's a lot of kind of biomedical excitement, and we're getting more and more into that, as well as in image-guided therapeutics. We have a whole big initiative using MR and CT and some of the optical techniques to make therapies more focused and less blind. So we actually provide imaging information during therapies for image guidance. Basically, the 4 areas of research that we have in our lab are fundamental optics, kind of imaging and spectroscopy for tissue diagnosis and early disease detection, optical therapies. We have very large programs in photodynamic therapy and something called ILP, which is interstitial laser photocoagulation, basically laser thermal therapy, elevating temperatures to coagulate tissue, and a lot of dosimetry and image feedback for that. We spin off a lot of some of our clinical findings or scientific findings into devices, and that's where we work a lot with that MARS Center, Medical and Related Sciences, in terms of forming clinical industrial collaborations and developing devices. And we have a big program in optical diagnostics, specifically endoscopic optical diagnostics, so gastrointestinal endoscopy, some pulmonary endoscopy, a little bit of ductoscopy, et cetera, but a lot of GI stuff. And I'll show you some examples of that as well. The reason we want to position ourselves in some of the things we're doing, I try to summarize on this slide, and I'll try to link it up to LITT as well, or LTTT, I'm sorry. So what's the future of clinical medicine if you look at kind of the larger picture? Probably the number one thing is not to get sick in the first place. So if you can prevent disease, that's the answer to all your cures. However, we're not going to discuss that because that's more of a socioeconomic and lifestyle and diet, exercise, genetics thing. But given the fact that disease is going to happen, the big emphasis right now, I think, is early disease detection and diagnosis. Early meaning actually pre-pathology or pre-malignant. And there's a big difference, of course, between detection and diagnosis. Detection is kind of a screening method where you have possibly a lot of false positives. Diagnosis is actually where you identify and perhaps stage the disease, and that's considerably more difficult to do. So the earlier you can do it, of course, the better are the therapeutic options and the better you can intervene and the higher the success rates. So that's on the one part, so that's the one wing if you want, and also obviously it involves a lot of medical imaging as well as other tests. On the other side, having gotten the disease and having perhaps diagnosed it and detected it, how do you cure it or how do you treat it? So there's a lot of improvements in things like medical oncology, better chemotherapeutic targeting drugs, in radiation oncology, better conformal radiation therapy, etc. Development of novel therapies as well, for example, such as photodynamic therapy or immunotherapy. But more and more of these therapies in this day and age are requiring quantification. They're requiring some kind of numbers, not blind therapies, but actively feedback therapy. So you actually know what's going on during the therapeutics, as opposed to waiting 6 weeks, 6 months, or even longer, and having the patient come back and find out if the treatment was or was not successful. So is there anything happening during treatment that can actually enable you to treat it better and perhaps even know what's going to happen as a long-term outcome? So less dependence on so-called blind treatments. And unfortunately, with maybe possible exceptions of surgery, some kinds of surgery, most treatments are blind. You have to wait to find out what happened. So actually in the United States, the National Institute of Health, the NIH, has coined this relatively ugly word called Theragnostics, which is the combination of therapeutics and diagnostics. In other words, why make the patient come back later if you're doing a diagnostic test, which can easily transform itself into a therapeutic intervention at the same time. So this is combining kind of medical imaging and therapy. So since this is a low-level laser therapy meeting, I try to kind of see if that links up. So can we use some of these approaches that I'll talk later on to quantify light dose, for example, maybe to quantify the physiological effects, such as the blood flow? Can we provide dynamic feedback? And if the answer is yes, and we have metrics for doing that, the idea, of course, is to improve outcome, not only to gain fundamental understanding and to improve the subsequent treatments, but actually to improve outcome in that particular treatment. So that's enough kind of generalities. Let me move on to the more specific technique that I think holds some promise in a lot of the applications that I'm involved in and potentially holds some promise for low-level laser therapy as well. And that technique, as I mentioned, was called optical coherence tomography, and I'll just, for brevity, keep referring to it as OCT or October, I guess, if you want to think of it that way. So it's an interesting technique that basically is in vivo microscopy. So it allows you to see subsurface with effectively microscopic resolution, and it enables you to do so in vivo. So you don't have to cut the tissue and put it under the microscope. You can see high resolution in situ in real time. And I'll also talk a lot about the work that we've done to extend this to so-called Doppler OCT. And Doppler is a term to quantify motion. And we're using that motion to quantify flow, specifically blood flow. And you'll see that later on how that works. And we couldn't do this without generous support of some of the Canadian government agencies, which we've been able to obtain. So how, I imagine most of you probably don't know and perhaps don't even care how OCT works, or only spend one slide on the physics of what's involved. It's basically an optical interferometry technique. So you take a laser or a light source, you split it. One part goes to something that you know, like a reference mirror, and one part of the light goes to something that you don't know, like your tissue that you're trying to image. And then you recombine the two reflectances, and it forms an interference pattern, and you analyze that interference pattern. And that's diagrammatically represented here. So you have essentially a low coherence light source. It'd be kind of like this laser diode, but not so good. It would not have such good coherence properties. It would essentially be a bad laser, some kind of a combination between this and the other light that comes out of here, somewhere in between. So that would be a low coherent light source, and part of the light is just through a beam splitter. This can be done in optical fibers, or it can be done in external beam, just with a glass light, for example. Part of the light will go to a reference mirror, and part of the light will go to the tissue. And what you do is you move the reference mirror back and forth. So you basically move something outside the patient. And what that does, because of the low coherence properties of the light source, it gives you an interference pattern, which is only defined within the coherence length of the source. So as you move the smear to different depth outside the patient, you're basically bringing into focus different interfaces within tissue. So you get like a line scan, or if those of you who know ultrasound imaging, that's called an A scan. So basically one line of profile. And then you can move it over, move the laser over, move the tissue over, and repeat again. And you can get a two-dimensional image this way. This is a little more of an engineering representation of how that looks like. So it's a lot of kind of optoelectronics involved here to get this right. There's also a lot of signal processing involved if you want to not only extract the reflectivity or the subsurface structure as a function of depth, but also want to detect motion. So all this signal processing block is to look at the phase of the signal, not just the amplitude, but the phase. And you can do phase processing to get Doppler information, which is related to motion, which is related to blood flow. So I'll speak specifically on this aspect of OCT, which we think is very exciting, because not only does it offer you structural information, it offers you functional information about the tissue, offers you information about the blood flows, specifically the microperfusion circulation level, which is very difficult to measure otherwise. So generally when I give a talk to a medical audience, people are quite familiar with ultrasound imaging. So this is a comparison with high-frequency ultrasound, effectively regular ultrasound being imaged through a finger. The finger's not being cut. That's just showing the imaging plane where the imaging is being done. So you can see speckle, you can see the stratum corneum, the epidermis, you can see the nail root regions. So the ultrasound image gives you fairly good resolution and fairly good penetration depth. So what we're going to do is do Doppler OCT within a much smaller square here. And so that's shown on this view graph here. Notice the scale bar, so it's not very deep. This is 0.5 millimeter, so we're only seeing maybe 1.5 millimeters in depth and about 3 to 4 millimeters sideways. But we see much better definition of the layers, somewhat less speckle, and just better spatial resolution all around. But we're not imaging very deep. That's something important. You're not going to see very deep with this technique. And in this panel, we're also showing these little color blobs, and those are actually related to microvascular blood flow. So those are perfusion maps of blood flow in tissue at the microcirculation level. And so this is summarizing some of the comparisons of the pros and the cons, if you want, or the differences between sound imaging, where you basically send a pulse and wait for the echo to come back, and it's a time of flight imaging. You can't really do that with light because light travels too quickly. So we do here, instead of time gating, we do this interference gating, this trick by moving the reference mirror and doing this low coherence interferometry. So it's somewhat similar to ultrasound, I guess. It has higher spatial resolution, better velocity resolution through this Doppler effect, as I'll show you later on. But the big disadvantage, something that you have to live with, is because of the scattering nature of tissue, you cannot see through the whole body. You cannot see even through centimeters of tissue. You can only see about 2 to 3 millimeters of tissue before the signal is completely lost. So just to give you heads up as to what this is all about, so it provides this optical coherence tomography, gives you non-invasive cross-sectional subsurface images with effectively microscopic resolution. So the properties of the light can be optimized such that the resolution is 10 microns, so 10 to the minus 5 or 10 to the minus 6 meters. So very similar to what you get in a conventional microscope in a histology lab, for example. And an important extension is the Doppler aspect of it can also image tissue blood flow, so microvascular blood flow, which I keep coming back to. So here are some of its big advantages. This is probably the biggest one, that you can almost think of this as an optical biopsy or a non-invasive method to see or to do what is currently done in a histopathological setting in vivo. So you can image not only structure but function through this Doppler extension. That's quite important. For the work, I'll describe this technology because you can engineer an optical fiber. It's actually compatible with fairly challenging applications such as intravascular imaging or endoscopic imaging. I'll show you examples of that. It can be non or minimally invasive depending on how you engineer the system and which organ you're looking at. It's harmless, at least compared to, for example, X-ray imaging because you're using low-level infrared light, so there's no dose penalty. There's no grays or centigrays or millisieverts that you're imparting to the patient. And relative to a lot of other imaging modalities, for example, MR, it's fast, cheap, and relatively portable. But nothing in this world is free, so there's obviously limitations. The biggest one is that you cannot see through very deep tissues. So it's shallow, about 2 millimeters, although with really, really fine detail within the 2 millimeters. Limited field of view, there's issues like in any other imaging modality about contrast and resolution, and just because everything looks great in terms of its characteristics, you still have to determine whether there's any clinical utility if you want to have this translated into a medical practice. So, is it worth it? Well, we'll try to answer that question as I go on. So the reason that we got interested in monitoring blood flow, especially at the microcirculation level, is in the field of cancer, in the field of oncology. This is a huge area. So people are realizing more and more that the vascular supply of normal tissue, and this is an electron micrograph showing that, is very different from the vascular supply of tumorous or oncologic, pathologic tissue. This, of course, is not true in every tumor and in every normal tissue, but in general, these characteristics are so. So if that's the case, can you exploit that difference between the vascular supply either to diagnose tumors early or to treat them differentially? So if you develop a vascular targeting treatment, and there's more and more of these anti-vascular, so-called anti-angiogenic therapy, that's a terribly long word, so I won't explain that. Can you exploit the difference between these two and preferentially leave normal tissue untreated and have the tumor respond to therapy? Or can you exploit this difference for early detection of tumors? So that's a big deal right now, and we're in this game as well. So it's important to note that at this microcirculation blood perfusion level, the flow in these tiny arterioles, venules, and capillaries is very complicated. So it's not like flow in a straight pipe, laminar flow you can predict and understand. This is intermittent, it's turbulent, sometimes it's so-called retrograde, sometimes the flow stops. It's very dynamic, very responsive, and very complex. So it's difficult to image properly. And in fact, most of the existing methods do not have the sufficient spatial or velocity resolution to properly get at these things. Doppler ultrasound is probably the closest clinical approach to monitoring blood flow. The clinical system, which work typically in the 10 megahertz regime, cannot have the sufficient spatial resolution to get at the blood flow. However, some of the experimental systems in high-frequency ultrasound are approaching this, but not quite there yet. So before I show you some of our clinical applications, let me just give you an idea of what this OCT technique can do if you engineer it right and if you enable fast imaging and do appropriate signal processing. So this is somewhat of a non-clinical model, if you want, but it's used a lot in developmental biology. This is a tadpole, and obviously I don't know the Portuguese word, but tadpole is a small frog, or it's the embryo of a frog. So this is, Giri, of course, I knew that, yeah. So that's a picture of it here, and we're imaging roughly in this plane where the heart is on this one. So let me just show you what you can do with OCT. If this movie plays. Right. So, yeah. Sorry. Right. So you can actually see in real time the three-chamber beating heart of the tadpole. So again, notice the scale bar. It's fairly small, 0.5 millimeter. So we're looking at 1.5 millimeters by 2 millimeters. And you can see the three chambers contracting and expanding in real time. It's kind of interesting. If you do some Doppler processing, which I won't get into, you can also look at the flow within the vessels leading to the heart, and that's what's shown here. Let's try that again. There. So these are the two vessels leading to the heart. So this is a little lower in cross-section. So this is the tadpole arteries leading to the heart. And you can see the flow, which we color-coded. There's some issues with the different colors appearing in there. And that's if everything was, if the science and engineering was done right, this would be indicative of opposite direction of flow. What's more likely happening is we have so-called phase wraparound. So this is when we do phase processing, and if the phase goes through a 2π cycle, it begins to look like it hasn't moved again. So what's happening here is probably some of these colors are wrapping around on themselves. I won't get into that too much. It's fairly complex. We can certainly come back to it during the questions and answers. So we wanted to move this technique to the clinic for PDT applications, for endoscopy applications, etc. But it's fairly challenging to go from the bench to bedside. So what we did is we dug into the literature, and instead of reinventing the wheel, we looked at what people have been doing for the last 50 years in ultrasound, which is a very mature, in fact, it's the most next to X-ray or about the same as X-ray, a used medical imaging modality, and it's Doppler extension. So we drew upon their robust techniques, which do all these crazy engineering things like coherent, demodulation, in-phase, and quadrature. It's okay, no, even most English people don't understand what that means. So I'm sure the Portuguese people even less so, or in Brazil as well. So I won't get into that, but basically you're measuring phase or change in the phase from which you can get the Doppler shift and from which you can get the velocity of blood if you know some other assumptions. It's also very tricky if you recall the previous two view graphs, is we're trying to monitor blood flow, but everything else is moving too. So we saw the three-chamber heart pumping. And also right near there's vessels with blood feeding through. So how do you isolate the motion related to the flow of the blood relative to the motion of the vessel wall of the heart itself? So there are some answers of so-called removing clutter. That's what it's called in ultrasound, to remove blocked tissue motion. I won't get into that, but we have to do that. So you get, I won't spend much time on this, you get different methods, different ways of representing flow. There's not a single number that describes it all. So things like color Doppler, power Doppler, velocity variance, which indicates how turbulent or how irregular flow is. You can also get the whole Doppler spectrum, and I'll show you an example of that in the next slide. This is a very useful reference for those who really want to read up on this for some strange reason. So here's another, before we get into the real clinic, here's another tadpole movie. And this actually has sound as well, if this works. So this is another cross-section through that little frog, through the tadpole. This is a structural image. This is going to be a color Doppler image. This is the turbulence image, or how variable the flow is, how high the variance is on the Doppler phase. And this, from here, we're actually going to listen to the whole Doppler spectrum. And it just happens to be that the Doppler shift is in the same region as the audio region. And if it works, hopefully, we'll hear it. There we go. So I don't know if you can hear a little swooshing happening. Yes. So if there's, I know this is a heart institute, so maybe there's any frog cardiologists in the room, they would understand if this is pathologic or normal. But so actually you're hearing the Doppler frequency shift spectrum represented in real audio. Anyways, so that's, so we're using actually this developmental biology model as a means of characterizing our system performance, but it's also of direct interest to some of the biology people that we work with because it's a fairly important developmental biology model in itself. So not only do they want to see if our system works, they actually want to know, is there a spiral valve, for example, in the 3-chamber heart, and how does the flow regulate itself around it? Okay, so let's move on to something more real. So we have, just to summarize this, we have many methods to represent moving objects: the blood, the artery, the heart wall, and that's what I was talking about, the color Doppler versus power Doppler versus variance versus audio sonogram, etc. Using this, you can actually separate the flow, such as here, from the block tissue motion, and that's quite important. So the first application I want to briefly touch upon is we've done a lot of work on endoscopic imaging. So this is imaging down a light pipe in the gastrointestinal tract. So this is a potential area where we think where the simultaneous imaging of structure, like possible to provide with OCT, and microvasculature, as possible to provide with Doppler OCT, can be combined and be useful. So this is one condition that's trying to detect early cancer or dysplasia in a disease in the upper gastrointestinal tract from the throat to the stomach. And this particular condition we are looking at is called Barrett's esophagus. Again, I won't get into that unless there's gastrointestinal endoscopy people here. But what we're trying to see is, as the tissue progresses from normal esophagus to a full-blown adenocarcinoma, for which there's very few treatment options, can we detect this early transformation when it goes to Barrett's, which you can see with conventional endoscopy. Let me just change this. Which you can see with conventional endoscopy to this stage where you can treat it much better if it progresses to a dysplastic stage. So that's what we're trying to aim for. There's another application which I'll spend the last part of my talk about, and that's monitoring of therapies using this combined approach. For example, PDT and potentially low-level laser therapy as well. So we'll concentrate on this one first. A brief slide as to what endoscopy is. It's basically a light pipe examination of the linings of the internal organs of the body. And the reason that's so important is about, at least in oncology, about 60% of the tumors, 60% of the cancers originate where the inside of the body meets the outside of the body. In other words, on interfaces. And quite often those are internal interfaces. So not just external interfaces like skin, but internal interfaces like the bronchus and the gastrointestinal tract, the bladder, and so forth. So the examination of these internal interfaces is very important. And so white light endoscopy, or light pipe examinations, is used routinely. The problem is it's not very specific and it's not very sensitive. So there's a lot of false positives, there's a lot of issues that are, or a lot of pathologies, especially early pathologies, that are being missed. So in the optics or biomedical optics community, there's a lot of work on using things like fluorescence, Raman spectroscopy, spectroscopic light scattering, OCT, endoscopic ultrasound as well, to supplement the information that the conventional endoscopy receives. And the reason that some of these techniques are really well suited to endoscopy is that the 2 or 3 millimeter imaging depth is not a limitation in endoscopy, because most of the structures are very thin and all the action really happens in those superficial layers, 2 or 3 millimeters, 1 or 2 millimeters, etc., which is a sampling volume for most of the biomedical optics techniques. So we spent a lot of time and a lot of work and a lot of money and effort and man hours trying to do this high resolution imaging at the end of a flexible light pipe. And the challenge, of course, is that it's flexible and it's in vivo. So the patient is breathing, the patient is moving, there's peristatic motion, there's esophageal wall contraction because of the heartbeat, because of the breathing. The nurse is screaming, the endoscopist is waiting for the next patient. So it's a very dynamic environment, and you have to do everything quick. And also, any motion of the possibilities that I mentioned basically will negate your whole imaging procedure, because everything will be blurred, everything will be washed out. So we developed some specialized tools and some micro-optical fibers. This was one of our probes. So this is the distal end. This is the far end of the flexible endoscope that goes, for example, into the colon and the esophagus. And through a hole, through a so-called instrument channel, we can engineer An optical fiber, which is represented this way with a Grin lens, a focusing optic, and a retroreflective prism, and have it move back and forth and produce two-dimensional images this way. This is about 2 millimeters in diameter now. We actually have much better probes than this. So this was, if I can move on. This was our system going from the clutter of our physics lab to the clutter of the endoscopy suite in the hospital. So the same system, but now packaged together, and we can move it to the hospital and obtain images from real tissues and real live human beings in vivo. So this is the kind of stuff that we can see subsurface. This is in the normal part of the esophagus, another normal. This is this condition of increased microvasculature called Barrett's. This is another condition called esophageal varices, which we won't touch upon. So you can see very excellent structural resolution. In fact, most of these types of structures have not been seen in vivo before, so the endoscopists are still interpreting this information, including, for example, this particular layer called muscularis mucosa is only 2 cells thick. So if you can see it, and if you can see if the pathology is penetrated below it, then you treat these diseases very differently than if it hasn't penetrated the muscularis mucosa. So there's a lot of information in these. And in addition, of course, the blood flow information is represented by these color blobs, is what we're really excited about. So this is basically the first demonstration of these types of images. We still don't really know what they mean. We're interpreting right now. So we're exploring this, if you want, the parameter space with previously unavailable information. So it's nice to get it. It gives you great publications, etc. But now you have to decide how to clinically use it. And you have to work with doctors for that. Also, to keep ourselves honest, we did a lot of immunohistochemistry and correlation of vascular staining with what we see in real clinic. And what we're trying to do right now is to image some patients between this and the adenocarcinoma in the intermediate stage, which has that dysplasia that we're looking for. It's not so easy. So we're continuing these studies. We're also trying to develop basically a features list or a method of classifying Doppler images, because again, that hasn't been done before, at least at this resolution. So we need to know what that means. And so we did some studies with other patients with other diseases. And this is one of the graduate students after a pretty tough day in the endoscopy suite, taking a little break, getting ready for the next patient. So now let me leave the endoscopy story for now and move on to a treatment monitoring story. So this is not early disease detection or diagnosis, but this is now treating the disease and trying to use this technology to improve the treatment of the disease. So that was the second application I mentioned as a possible method for using structure and vasculature at the same time. So before I move on to PDT, we did a couple of simpler studies, if you want. And this was to look at antivascular chemotherapy. This is so-called anti-angiogenic drug. This is a whole method of trying to treat cancer without treating the cancer cells. You treat the blood supply to the cancer cells, and you try to exploit that difference between the vascular response and the vascular architecture of normal tissue versus pathologic tissue. So this is one of these crazy names from a drug company that's trying to market this drug to use in conjunction actually with radiation therapy, ZD6126. And so we designed a simpler than the endoscopic, but a simpler handheld imaging probe that we can image in a mouse with the similar characteristics of what we had endoscopically. And this is basically showing us a normalized blood flow index, volumetrically averaged from this imaging plane, so on the vertical axis, and time after injection of this antivascular drug on the horizontal axis. So you can see, at least in this one animal, a fairly significant and fairly reproducible reduction in blood flow, so vascular shutdown. And you can actually monitor that in real time in live animals as opposed to doing sequential histologic studies, which of course is very disadvantageous. So that was promising. So what we also did is we've initiated, since we do so much PDT in our laboratory with Brian Wilson and a bunch of other people, we initiated this Doppler OCT for monitoring of PDT. I imagine most people here know what PDT is. It's photodynamic therapy and how it works, and it's the pros and the cons of it, so I'll just spend maybe 1 or 2 slides on that. The basic idea is it's basically chemotherapy with light activation. So you inject a drug that doesn't do anything on its own other than potentially congregate or localize around the tumor site. But if you do nothing after that, then the drug eventually clears and nothing happens. If, however, you shine light on it, generally red to near infrared light, then the drug becomes photoactive, passes off its excited state to things like singlet oxygen, and they become very active as well, and there's biological damage. So the big advantage of PDT is that it's got two methods or two ways of minimizing normal tissue damage. So if there's no drug or there's no light, then there's no PDT effect. So it's a combination of those two that's needed. And so you have two methods of sparing normal tissue damage. It's a fairly complex technology. You got to get the light dose right, just like you do in LTTT. The drug dose and the pharmacokinetics is a function of time. So the drug distribution you have to watch for. Oxygen concentration, there's photobleaching complications. There's issues about PDT mechanisms and targets. It's not a very simple thing to do correctly. So it just means that if you have a method of monitoring how the treatment is proceeding, you can actually do it more correctly by feedback on it. So again, that's just a brief thing about PDT fundamentals. I mentioned some of these things before. It's interesting that most of the damage, unlike, for example, ionizing radiation, is not nuclear DNA, but generally cell membranes, sometimes mitochondrial DNA, and quite often it's not cellular damage altogether, but vascular damage. So you're damaging the endothelial linings of the vessels as opposed to the cells. So I mentioned some of these advantages: minimal side effects, localized treatment. The normal tissue healing is very good. Unlike radiation therapy or unlike some chemotherapy, you can retreat as many times as you want. There's no long-term resistance and there's no cumulative dose limitations. But it's got some disadvantages: complex. It's not suitable for treating very large tumors or even sizable tumors. It's better for smaller tumors. And for most applications, with a couple of exceptions, there are other existing modalities for these treatments. So PDT has to really prove itself to make a difference. And the treatment planning is different, which again leads us to using some of the technologies we're developing to optimize those treatments. So we started this fairly early, about 3-4 years ago, and this is showing basically following PDT, our Doppler OCT image and Doppler OCT image as a function of time following PDT therapy. This was photofrin in a particular rat cancer model, rat prostate tumor model. And not surprisingly, there isn't a heck of a lot of change in the microstructure. The pictures, at least to a first approximation, unless you do some speckle analysis and so forth, look very similar. The Doppler pictures, however, show significant differences. So we were kind of encouraged by that. And we also wanted to see what's actually happening during treatment, as opposed to just following different times after treatment. So we went further and did some in vivo during treatment imaging. This is using a different photosensitizer. This is a much more vascular targeted sensitizer, not like photofrin, which is mostly structural targeting, cellular targeting. This is something called 2CAD. It's a plant chlorophyll-based photosensitizer. This again was done in a mouse model. So this is a fairly interesting result. Again, plotting some representation of the Doppler signal or blood flow versus time. And this shaded region is the region during the PDT light or radiation. So what it's showing us, if the data is to be believed, is that there's significant vascular shutdown or loss during the treatment, which of course means that most of this light is wasted. There's no sense shining light if there's no blood supply, because if there's no blood supply, there's no microvascular oxygen present to initiate the PDT effect. So this has significant implications, if this is right, for optimizing the treatment. And this is the kind of information that you simply cannot have most other ways. You would only find this out if it were not later on, several weeks or months after treatment. So this gives you some online monitoring possibilities. And so we're investigating how much this depends on the tissue type, whether it's normal tissue or whether it's tumor tissue, what type of cancer model, et cetera, and what type of PDT dependence there is on the light levels, on the type of drugs, et cetera. One other push that I just wanted to mention in the last application is we tried to overcome the fact that OCT can only image to about 2 millimeters in depth. So what we did is we developed a distal probe, sub-millimeter needle, which will make the technique not non-invasive, but at least minimally invasive. So we can place this needle interstitially deep into tissues in a minimally invasive way and monitor microvascular blood flow deep in the tissues as well as microstructure. So we're no longer limited to near surface regions. And so this is the OCT gun, if you want, that we developed. This is some detail of the distal optics using ball lensing and using some of the optical modeling methods we've developed to try to focus the light better. And so basically, the bottom line is we now have a probe that's a fraction of a millimeter in diameter, which we can place. Again, it's a non-invasive, but it's a minimally invasive poke, if you want. But we can be placed anywhere in three-dimensional space and deep into tissues, and then we can monitor effects. So this is showing details of the probe. This is showing some of the early data. The structural image is a function of time, and then the blood flow image is a function of time. This is a little quick movie looking at the structural image in a tumor model, the Doppler, color Doppler, and the velocity variance image. So these two are monitors of blood flow. And this is going to go from before the treatment to during treatment to after treatment. And if I can get this to work. So it's maybe not as exciting as the tadpole beating hearts, but it gives you some more clinical information. So you can see the vascularity, at least these two vessels are being shut down. And then after treatment, actually they rebound up a bit. So this is post-PDT. And you can see some of the blood flow returns, at least in the velocity variance image. And this is playing the loop again. So this gives us some quantification of, at least for this PDT regimen, what's happening on the blood flow side. And just to put it in some words, people say that a picture is worth 1,000 words, but really more and more, a quantifiable number is worth many pictures as well. And I didn't put what X is, but you can guess yourself. So let me quickly conclude, because I think my time is running out. So at least with this interstitial approach, we have deep tissue imaging possibilities with a sub-millimeter fiber sensor, so it's no longer limited to near surface or endoscopic applications. The effects we're seeing are very complex, very dynamic, and at least we can detect them. So now it's up to us to work with clinicians, with biologists, with other engineers to interpret these effects and to make something useful out of them. And there's significant feedback possibilities, not only for PDT therapy, but for other variety of, so what I would call blind therapy, such as radiation therapy and anti-angiogenic therapy, if we can use this information, and possibly this low-level laser therapy applications as well. In the interest of time, let me skip a couple of these other slides. This is technology improvement. For those of you who are engineers may recognize micro electromechanical systems, so we're using some deformable mirrors and variable focusing in collaboration with some engineers in Stanford University. This is back to our tadpole, except now we've improved our imaging system considerably, so we're imaging much faster. We can do gated imaging, just like they do in cardiology, fairly repeatedly, fairly readily. So you can see some of those hearts, but you can see somewhat faster and somewhat less speckle, and so you can quantify these images considerably better. And you can do three-dimensional rotation and basically blood flow within a moving object, which is quite challenging. This is what they do in MR a lot. And you can do this partial filling effects, just something to entertain you. Again, this is copying to what other medical imaging modalities routinely do with fly-throughs and things like that. This is a one-slide summary of our endoscopy work. In case you were asleep on all this time, I had to put in a one-slide summary for the director of our institute. Okay, so let me conclude. So where we're going with this is we're trying to improve the performance, being physicists and engineers. So we're looking at Fourier domain or frequency domain OCT, ultra high resolution, basically better light sources, micro electromechanical systems I mentioned, to enable, at least on the structural imaging, to basically see cells in vivo, which we haven't been able to do yet, but we're moving that way. Any respectful medical imaging modality has to have contrast. Every other imaging modality has contrast agents. OCT so far doesn't. So we're looking at that possibility as well. We're expanding our studies from gastrointestinal and PDT to things, as I was mentioning, regenerative medicine and stem cells, lung cancer, antivascular drugs, interventional cardiology, etc. And it's, we feel it's an imaging platform for many sites and programs, both on the diagnostic side, on the treatment monitoring side, and we're pushing through with it. So it's quite an important, I think, technology for disease assessment and treatment monitoring with potential applications to LTTT. And of course, I didn't do any of the work. All these other people helped us and did the work, and these people supplied the money. And I thank you very much for your attention.
Well, I have one. Can you
I'm
start?
sorry.
Maybe I encourage people to go.
Sure.
When you show about the vascular shutdown during PDT, this is very superficial. With PDT, we go much further in.
Right. Well,
what OCT can go.
Right. So that data was from a deep part of the tumor. So this was not in the surface region of the tumor, but this is about 4 millimeters in depth.
Yeah, but then you have to needle it.
Yes, we do.
But then the needle will be a shuttle for some of the light.
We have control experiments, as you probably imagine, where we place the needle, and we do all our Doppler OCT measurements, but there's no drug or no light, or only drug but no light, or only light, no drug. And so those generally do not show vascular changes. So whatever changes we see are actually due to PDT and not to the placement of the needle, or not to light alone or drug alone. So we try to account for that, of course. If you poke the tissue, there's going to be bleeding.
Yeah, but then it's not really a real-time type of that. You're going to have to alternate PDT with this.
Oh, no. We don't do that in the same animal. So we do the control experiments in a different animal, or at least in the same tumor, but not in the same treatment session.
She wants to ask you the following question.
But can you translate?
How can we use OCT for evaluation of low-level laser therapy?
I was hoping you guys would answer that question. Well, I mean, an obvious approach is to quantify the microvasculature, right? In low-level laser therapy, there's probably increased perfusion during the several minutes of low-level irradiation. If that can be quantified and compared with the eventual clinical or preclinical outcome, that would be a real-time feedback possibility. The nice thing about microvasculature is it's bound to change. The challenge is how to measure that change reproducibly and how to relate it to something clinically relevant, because it will also change if you simply apply pressure. So that would not be a good diagnostic tool to predict eventual outcome. So I think in the context of LITT, you can just quantify microvascular changes during and perhaps immediately following the therapy, and try to relate those to the treatment parameters and to relate those to the clinical outcomes and see if there's appropriate correlations.
Can you follow the angiogenic effects in lesion, for example?
Actually, that was one of the slides I skipped there, or I went over very quickly. We were trying to do that. The angiogenic effects are happening relatively slow. So the new vascular formation or vascular shutdown, at least the vascular formation is of the order of hours to maybe days. That is difficult to do. It's difficult to image in a longitudinal fashion that way. You can do snapshots. So you can do half an hour imaging session today, then tomorrow, and the next day. But continuously to a lapse movie in vivo, that's very challenging. That's a good question.
So if we have no more questions, let's thank again Alex for the nice talk.
Okay.